Good morning to all respected chairpersons, my teachers and delegate friends. So today I'll be talking on that what is the added advantage of spectroscopy in MSK tumors. I'll be showing cases, around 13 cases I'll be showing. So I'll show my experience in the MSK tumor, how that spectroscopy helps in diagnosing and differentiating various tumors. So my learning objectives will be the role of conventional MRI imaging in the assessment of MSK tumors. And second, I'll be highlighting that how the spectroscopy helps in characterization and differentiation of the various tumors. So as the for bone tumor or MSK tumors, the conventional MRI still play important role in differentiating various benign as well as malignant tumors. So conventional MRI provides the local tumor extensions. You can see the bone involvement, bone marrow involvement, extension into the joint space, and destruction of the articular cartilage, any encasement of the neurovascular bundles, and we can able to do the local tumor staging. So here, the topic of my importance is that how that spectroscopy provides some information and helps for the radiologist giving the the adequate diagnosis to the clinician, to the surgeons by observing the chemical content of the tumor. So this MRS able to detect, either it can able to detect that choline peak, or it can able to assess that choline creatinine ratio, and which have importance having sensitivity of 95% in differentiating various tumor. So I'm not going detail that what is the spectroscopy technique. We can do either single or multifocal. The here most important is the water suppression, because if you don't do proper water suppression, there will be large peak of water which suppresses the all metabolite in MSK tumors. So we commonly use the press, the point result spectroscopy technique. The placement of voxel is also important. We have to select that area to be do spectroscopy, that where the tumor look like a bit solid, where in contrast images we can get contrast uptake, and we have to try to exclude the bone, head, muscle, and necrotic area of a tumor. So when you get any cases of soft tissue tumor or MSK tumor, we have to evaluate the location and site of origin of the tumor. We have to find out the epicenter of the tumor size, what is the signal intensity on T1, T2 images, any presence of periosteal lesions. As I have said, that joint involvement, bone marrow involvement, any extra compartmental extension of the tumor, neurovascular encasement, then pattern of the diffusion restriction is very important. Nowadays, that ADC calculations helps also in differentiating various benign and malignant tumor. And then ADC mapping also help to see the post-treatment response. When there is increases ADC value after treatment, chemotherapy or radiotherapy, then it reflects that the tumor is responding to the treatment. So I'll be showing the cases. Basically, that will be very helpful to the residents. So this is a case of 13-year male patient presented with progressive swelling in the right lower thigh. This plain radiograph AP view shows there is ill-defined lytic areas as well as bony sclerosis, some dense bone formation in the peripheral area, the huge soft tissue components. So by seeing that age is also important, site of bone involvement is important, it is affecting the central part of the bone. So these give some clinical hues to the clinicians, to the radiologists, that what tumor we are dealing with. So if any, as a radiologist, we have to always try to see the plain radiograph before going for differential diagnosis on the MRI. The same patient see that the huge soft tissue mass lesions with involvement of the whole of the femur, the medullary space is involved up to the lower 1/3 regions. This bone is a bit widened in the medullary space, large soft tissue component. This is a post-contrast MRI images, so irregular enhancing heterogeneous soft tissue mass lesion with large areas of necrosis. So while seeing these images, so the placement of spectroscopy is important. We have to put the spectroscopy at the peripheral part of the tumor, not in the central necrotic area, and always try to avoid fat and bone. So the same patient, this is the axial T1, and this is the placement of the voxel. So here we are putting the voxel in the peripheral solid looking area. So this is a large peak commonly in the MSK tumor. When you do spectroscopy placement of the MSK tumor, always we get the contamination from the fat. So definitely we get the fat in the 120 parts per million from the contaminations. So in 3 parts per million, we are getting the choline level. So if you do that, measure that choline creatine level or choline creatine ratio in most of the MR scanner having, we can able to measure that choline creatine ratio. So here these patients, we have calculated it is 37, around 37, and we have done biopsy from the solid non-necrotic area. It shows fissures of osteosarcoma. So coming to the second case, it is the 36-year female patient presented with pain and swelling in the right lower thigh. Here, that the plain radiograph gives clue to the clinicians, to the radiologists, what we are dealing, because it is the lesion is aesthetically located. It is not in the central. So when you see the aesthetically located lesions, osteolytic lesions, some septations are there, minimal soft tissue component is there, we are sure that we are dealing with some benign condition or like GCT. So this patient underwent MRI images. This is the sagittal T2 MR images, T1 and axial T2 MR images. Here we are getting the aesthetically located soft tissue mass lesions. See that the lesion inferiorly extending to the joint space, or you can extending to the subarticular area. So involvement of the joint space or subarticular extension is more in favor of giant cell tumor. And that the soft tissue lesion shows heterogeneous enhancement with some areas of necrosis. Here we have, this is another important parameter in spectroscopy that we can able to map the metabolites. So this is a metabolite map. The red area show more hard or more malignant tissues, more hard nature of the tumor. And when you see the curve, the red is the hard, then becomes softer in the blue area. So while doing the biopsy, or while you want to go for some FNAC or biopsy, you can put that needle in this red area. The spectroscopy of this patient shows some small lipid-like peak. This is assumed that we always get in the MSK tumors. Here we can able to see that choline creatine ratio is raised, and this choline creatine ratio is 6.6. So that is the GCT on histologically diagnosed, but the GCT is the one of the benign tumor, what is called quasi-malignant tumor, which shows high choline creatine ratio. So this is the exception. So GCT is the exception, that is a benign tumor, but it shows significant raised choline creatine ratio even in the spectroscopy. So this is a 34-year-old male patient having swelling in around the shoulder. See the X-ray. So residents should able to diagnose this case by seeing the X-ray. What we are dealing, because we are dealing with some large ill-defined sclerotic or lytic lesions. So newborn formation is there, adjacent soft tissue component is there. So by seeing the X-ray, we have to look for what is the common differential diagnosis in these patients. So this patient underwent MRI. This T1 weighted MRI images show involvement of the proximal humerus. Shaft is also involved. Soft tissue component is there. The T2 shows some isointense to mixed signal intensity tumor. ADC shows variable ADC with some areas of low ADC value. If you see the post-contrast MR images, see this involvement of the medullary space of the bone, cortical destruction is there here. The huge soft tissue component around the affected humerus. See that we can some same images, we can able to see the multiple nodules in the lung. So that also helps in diagnosis. And spectroscopy here, so large lipid peak is there. It is assumed that it is because of contamination from the fats. So here that choline peak is seen. We are able to measure the choline creatine ratio 13.3, and we are getting multiple metastatic nodules in the both lungs. So this is a case of osteosarcoma with metastasis. So 34-year female patient presented with left buttock pain. Here we are getting large ill-defined osteolytic lesions. Some sclerotic septations are there. The margin is look a bit smooth. We underwent MRI. On MRI, this is a T1 weighted MRI, so isointense soft tissue lesions in the iliac bones. This is the T2 ISO2 slight hyperintense soft tissue components. So PDFS shows hyperintense to isointense soft tissue lesions. See the narrow zone of transition in the iliac bone. It is iliac bone destruction is not too much irregular. If you see the DWI, it shows diffusion restrictions. On post-contrast sagittal MR images is showed homogeneous enhancement. There is homogeneous enhancement, no significant necrosis, just non-enhancing septations are there. We underwent spectroscopy. Spectroscopy, lipid lactate is a normal. Here see the choline creatine ratio slightly raised. The ratio is 2.1. And then histopathology shows in the case of condomyxoid fibroma. So that conventional X-ray, plain radiograph always helps the radiologist or the clinician for diagnosis of the tumors. So another case of 20-year male patients. this patient came to me with the lytic lesion in the fibula. See, if you see the magnify images, there is ill-defined lytic lesion in the fibula. The cortex is irregular. There is widening of the intraosseous space, minimal soft tissue component around the lesions. So from plain radiography, it is very difficult for us what condition we are dealing, either benign or malignant. If you see that MR images, see MR images very big rule in such situations. You very nicely see that involvement of medulla of the fibula. There's a huge soft tissue component around the fibula. The fibula, then some T2 hypointense. This is a PDFS images. T2 hypointense, some septations are there. See the classical dumbbell-looking mass lesions with large posterior medial components. The lesion causing widening of the interosseous space. The fibula is affected. And this patient underwent, we are putting the spectroscopy in the solid appearing area. This is choline creatinine ratio is, we are getting the 13, and histopathology picture shows features of malignant fibrous histiocytoma. So the malignant fibrous histiocytoma common in the leg commonly affect, we can found in the muscle, and it is extension into the interosseous space. So coming to the case 6, is a 15-year child presented with swelling. In X-ray, we are getting some periosteal reactions is there, irregular periosteal reactions, medial as well as lateral aspect of the tibia. Some ill-defined haziness is there. Just this space is widened here, some soft tissue components. So we are doubtful what condition we are dealing on the plain radiograph. So if you see the MR, the picture is different. See that huge soft tissue mass lesion is there. It causes acentic irregular osteal destruction of the tibia. This is isointers on T1 MR images. It shows soft tissue component. See that medullary extension is very extending up to the mid-third of the tibia. So this patient underwent a diffusion. The diffusion show low ADC value. So it indicates some high cellular tissues are there. On contrast, it show irregular areas of enhancement, extensive areas of necrosis, periosteal lesion, newborn formation, medulla involvement. The cortical destruction very nicely seen on the axial post-contrast MR images. We underwent the spectroscopy. Here, the choline creatinine ratio is 14. This is the large choline peak, 14.2. And histopathology, we underwent biopsy, shows that Ewing sarcoma. So this is a 34-year male patient. In plain radiography, it is very doubtful what we are dealing, but look like some subtle osteolytic or some subtle lucency there in the distal end of femur. See that X-ray and the MR is a big difference. If you see the X-ray, it is very difficult to see any lesions, but if you see the MR, what happening? The huge destruction of the distal end of femur. It is extending to the patellofemoral joint space. The joint space, patella facet is also involved. Joint space extension is there. On contrast, so irregular enhancement in the huge areas of necrosis, superior extension into the distal third of the femoral shaft in the medullary space. And see that soft tissue component destruction of the cortex is very nicely seen on the axial post-contrast MR images. Spectroscopy you have done, it shows to raised choline peak. The value is very high, it is 51.6. So on histopathology, we underwent biopsy and it shows fibrosarcoma. Any resident can able to diagnose this case? Spotter. I will put in the spotter in the quiz. So this is a 60-year male patient presented with swelling in the forearm. This is a bones appear osteopenic, but there is huge osteolytic lesions, causes expansion of the medullary space, newborn formation, septations are there. Very angry looking tumor. We are dealing with a very angry looking tumor. Some ossifications are there inside the lesions. So see that MR, this is the PDFS and this is the T1. These images show huge soft tissue component, destruction of this bone, multiple septations are there which become hypointense. This patient underwent spectroscopy, axial post-contrast images show significant destruction of all cortices of the affected bone, soft tissue component. Spectroscopy shows the raised choline level with choline creatinine ratio of 42. Biopsy shows features of chondrosarcoma. So case 9, the 47-year female patients, irregular osteolytic lesions. The zone of transition is very irregular. So this patient having wide zone of transitions. When you're dealing with a wide zone of transition, we suspected that we are dealing with the malignant lesions. So benign tumor usually having, normally having low or narrow zone of transitions. So this patient MRI is T1 weighted MRI images. The huge soft tissue component, irregular destruction of this bone. Minimal soft tissue component here also, you can see able to see the bone is irregularly destroyed. The zone of transition is widened. The diffusion restriction is low additive value. It is a high malignant tumor. And see that on axial post-contrast images, destruction of the cortices of the bone. Spectroscopy show raised choline level, choline creatinine ratio of 23, and biopsy shows all the lymphocytes. So this is a lymphoma. So this is the case of lymphoma. So case 10, 70-year male patients. So for radiology, it is not difficult to define that we are dealing with some lipoma, lipomatous tumor, huge soft tissue mass lesion, bone is intact. On post-contrast images, you are very seeing that minimal subtle peripheral enhancement, some septal enhancement is there. And spectroscopy shows large lipid-lactate peak because of fat contents. The choline K2 ratio is very minimal, choline K2 ratio is 1.1. On biopsy, it shows is a case of well-differentiated liposarcoma. So coming to the case 11, the 36-year male patients. See when you see the T1 and T2 hypointense, so we are dealing with some hypointense lesions who both shows low signal on T1 as well as T2 weighted images. The bone is normal, there is no bone involvement, minimal peripheral enhancement on the post-contrast MR images. Minimal peripheral enhancement here also able to see the septal enhancement is there, bone is intact, spectroscopy was done, shows minimal choline K2 ratio of 2.8. The biopsy shows desmoid tumor. So T1 and T2 hypointense also helps in diagnosis of the tumor. So we have to note the signal intensity of the tumor. The case T, it is an irregular destruction. 12 is an irregular destruction of this metatarsal bones. The 66-year male patients. The huge soft tissue component is there. If you see the plain T2 axial MRI, this is the coronal images. You see the expansion of the bone, huge destruction is there. And same patient having heterogeneous enhancement of the post-contrast enhancement, having liver lesions here, adrenal metastasis is there. So this is a case of acral metastasis. We have done spectroscopy, it shows choline K2 ratio of the 21s. So histopathology, it shows metastasis from the adenocarcinoma. So it is a very difficult last case. This is a 13-year female patient with progressive swelling of the radius. It is very doubtful. Initially, I think this is a case of osteosarcoma. It's because see the sun-ray appearance of the bone, newborn formation is there, medulla expansion is there. It's very difficult for radiologists to diagnose. Initially, we thinking this is osteosarcoma, but it came to be different. So this patient underwent MRI. This is the T1 weighted MRI images. So expansion of the bones. So T1 hypointense newborn formations. The PDFS shows involvement of the medullary space. Sagittal also shows involvement of the medullary space expansion, minimal soft tissue components around the lesions. This is axial MR images. See the bone, newborn formation. It looks like sun-ray appearance of the bone formations. It shows contrast enhancement of the soft tissue components. It's very difficult for diagnosis on MR as well as plain radiograph. This patient underwent post-contrast MRI, so heterogeneous enhancement, diffusion, so strong diffusion restriction is low additive value. So it helps that we are dealing with some malignant conditions. And this patient underwent ultrasound-guided biopsy. It came to be a plasmacytoma. So it is a very rare presentation of the plasmacytoma because as a radiologist, we know that plasmacytoma is usually osteolytic lesions. So coming to last part, the how that choline K2 ratio helps. We have done 42 cases in my study series. We have got that ranges of the mean choline K2 ratio in benign condition is around 7. Because this value is high because of GCT. Because BCT we are categorizing to the benign lesions because its behavior is look like malignant. And in malignant lesion, it is around the 25 to 27. So we have published this, how the spectroscopy helps in differentiation of the MSK tumor. Here I can emphasize that the ratio is very important. When you get choline K2 ratio more than 7, we have to think for malignancy. And another important, we have published another study that how the DWI also helps because the DWI additive value is also low in the malignant tumor, high in the benign tumor. The additive value not helps in diagnosis of the benign and malignant, but it helps in tumor response after treatments. So after treatment, the additive value will be increases. So another study, they have only able to identify the choline peak, but they are not measuring the choline K2 ratio. See, nowadays, because most of the T Tesla MRI having, we can able to measure the different metabolite ratio. Actually, we can also able to calculate the level of the choline if you do the LC model software. So various previous study, this is also from us India. They also able to characterize that different spectroscope having the peripheral skeletal lesions, but here they found that GCT usually show the choline peak because see GCT is the benign, but still they behave as a malignant. So that is the reason. So GCT is we have to exclude the GCT. If you want to do some study in future that the differentiation of benign and malignant, we have to exclude the GCT. Otherwise, GCT come to the play in between these two conditions. So the limitation, there are some limitations is there. Sometimes spectrum containing only noise without any identifiable metabolite peaks. So we have to exclude the such cases. And second important, if you do MR, we have to use proper water suppression. If you don't do proper technique of water suppression, you get huge water peak. It suppresses the old metabolite peaks. And excessive lipid contamination, we are always assume that lipid lactate always come into the spectroscopy in the MSK tumors. So now I did last slide, okay. So I'm concluding, this is the last slide. So we have to think on MRI, we have to see the size, margin, as I have already told, cortical destruction zone involvement, extra compartmental spread. And this heterogeneous pattern of contrast enhancement were significantly more common in the MSK, malignant MSK tumor than the benign conditions. So this spectroscopy is not helpful in diagnosis, but it provides added advantage in differentiating these benign and malignant conditions. So thank you.